Are you on a medical aid or hospital plan and the medical aid scheme or insurance refuses to meet their obligations? What is the difference between a medical aid and medical insurance, and how will the NHI impact the medical aid schemes? Hello and welcome. I'm your host, Dr. Mosam Tombeni. Signing with us is Nomsa Matebula. On Vital Signs, we focus on medical aid costs in South Africa. Medical aid costs in South Africa are dependent on the type of medical aid plan you subscribe to. Now, monthly contributions are obviously based then on the benefit structure and the level of cover that plan provides. Coming up on the program, we'll listen and look at insert produced by Wandile Mufukeng. He spoke to a man and a woman about the challenges that they face with their respective medical aid schemes, and they shared their story with us. We'll speak to GM of New Markets in Discovery Health about what medical aid scheme is and how we can help you with regards to your health needs. We'll also speak to Executive Head of Sales and Services from Time Health about what the difference is between a medical aid scheme and health insurance. And we'll wrap things up with a technical specialist from the National Health Insurance, of course, from the National Department of Health, about the role of private healthcare and medical aid schemes once the National Health Insurance is implemented. Remember that you can be part of the show by asking the guests that we'll have on the questions that you have on your mind by simply sharing your views on what we're discussing. The number to call is 011-714-5861 or 011-714-5877. You can also share your views with us on social media, on Twitter at SABC Vital Signs, or Facebook is SABC Vital Signs. Show continues right after this ad break. Stay with us. Welcome back to Vital Signs. Now, 59-year-old Samson Tom Ndlovu from Pretoria in Attridgeville feels hard done by his medical aid as he claims that they ask him to pay 30% of his medical bill. He sat down with us to share his personal experience. Take a listen.
I have diabetes. It was diagnosed in 1996. And then diabetes has caused high blood to also erupt. And I've got also renal failure. That started 3 years ago, a renal failure. Yes, and then I've got also heart problems.
50-year-old educator Mr. Solomon Ndlovu from Attridgeville in Pretoria is living with diabetes, which is a chronic illness. We visited him at his home as he has issues with his medical aid, which he thought would help him with his health condition.
When I started with the GEMS, they were paying everything well. But when times goes, they've started to change for me, especially. I feel hard done by the medical aid, because now the medical aid is paying a portion. I'm also paying the difference.
For the past 4 years, Mr. Ndlovu claims his medical aid was paying half and he has been paying the difference. He was shocked to find out when he was hospitalized that he now needs to pay 30,000 on top of the amount paid by his medical aid.
The one that makes me feel hard done by is the one that the hospital has asked for 203,000 rands. The medical aid has paid a portion. They say I must pay 32,000 rands. The difference that they didn't give the hospital. But I was also surprised why such an amount. To install the graft, they charged 65,000 rands last year. This year, February, I went. They ballooned the graft so that it functions. But I was so amazed to see the price, the amount that the hospital asked from the medical aid.
At this point, Mr. Ndlovu feels he was charged more for a small operation that he did.
Went to the medical aid to ask the medical aid to intervene, because I think maybe they've charged the medical aid for the wrong operation. We are promised that when we are in hospital, the cover is 100%. But now I have to pay the difference of 32,000 rands. So I'd like them to be honest to us and do as they promised.
After the break, we'll speak to Nonkululeko Piche, the GM of New Markets in Discovery Health, about what medical aid schemes actually do and how they can help you with regards to your health needs. Stay with us. Welcome back to Vital Signs. Now, Elenise Golden from Johannesburg and Northcliffe isn't happy with how her retired mom's medical aid is treating her with regards to payments concerning hospitalization, medication and doctor's visits. Due to the nature of a developing medical condition called lupus, the medical aid says she is not, or they are not, recognizing it as a chronic condition, and therefore they refuse to pay for it. Let's take a listen to her story.
My mom was permanently employed until she was 55 when she retired. She's 71 now. So she's been on the medical aid through her employer, and then when she retired, she just continued in a personal capacity on the same medical aid, just changed the plan and downgraded a bit because of cost, obviously.
Annalise Golden from Northcliffe in Johannesburg is speaking on behalf of her mom, who is retired, and they have been having issues with her medical aid. Her mom was diagnosed with lupus a year after she retired. Right after, she continued with the medical aid on her personal capacity.
Like I said, there was no break in cover, continued on the same medical aid, just transferred to a personal capacity. So then lupus was obviously registered as a chronic condition for her. And then lupus, because of the lupus, she got osteoarthritis and all of the things that comes with lupus. So then in 2019, she hurt her hip. And because of the lupus, it's affecting her joints and bones and all of that. So she needs a hip replacement.
Elenice's mom downgraded her medical aid plan, which still covers her for lupus. Lupus is a health condition that can affect any part of the body, and for Elenice's mom, it affected her joints and she needed to do an operation. She was declined by her medical aid.
What we tried to explain to them was that because of the lupus, which is a prescribed minimum benefit, which, that is the reason why she needs the hip replacement, because it's all linked. They then still said, no, it's declined. And then we said to them, okay, if you can then submit the forms to us so we can apply for an ex gratia payment.
The Goldens upgraded their medical aid plan just so they can get the operation done. But unfortunately, COVID-19 happened and her mom couldn't get the operation.
Decided to upgrade a plan to have the op covered, because obviously they see it on the plan she's on. It wasn't covered, and then, like I said, COVID happened, so the new plan that we upgraded to firstly it wasn't guaranteed that it would be covered, but then her day-to-day benefits were less. So things like optometry, dentistry, things that she needed wasn't now covered on the new plan.
She feels that the medical aid needs to dummy down their communication and jargon when they offer people medical aid.
I think where the medical aid really failed us is because they don't explain things. Firstly, the reason why I understand more is because it's the field I'm in. I am in the medical pharmaceutical field. But speaking to a 70-year-old, she doesn't understand all the medical jargon they use, and all. So as a result, I have to cover all the time. I have to do it when she's with me because they won't give me the information unless I put her on the phone to approve, So it's really been up and down, up and down.
Medical aid covers members' healthcare costs such as hospitalization, treatments and medicines, and these costs are covered according to the rules of the medical scheme and the members' medical aid plan types. Now, these rules, of course, ensure that the members are fairly cared for, and here to talk to us about what medical aid is and how it can help you with regards to your health needs, we're joined by Nonkululeko Piche, the GM of New Markets and Discovery Health. Good day. Thank you for joining us.
Thank you. It's wonderful to be here.
Good. So let's talk around the idea of what medical aids actually are and how someone gets into getting a medical aid.
So, in simple terms, the core of a medical aid is to fund and to help members in their time of need from a healthcare perspective. Being in this business for quite a long time, and actually at Discovery, we've decided, and we actually made this decision a while ago as we saw the transformation of how people were consuming medical aid, that it's not just about the funding, it's beyond the funding. And having listened to some of the stories that you played this morning, is that the key is that people need peace of mind and protection. Funding is one component, but it's how you fund. People talked about out-of-pocket expenses. That's the kind of thing we agonize about. The reason why we work with doctors, create networks, work with hospitals, because the worst thing that can happen to a person is that they enter a healthcare facility or go see a specialist, and then there's an out-of-pocket expense. So we don't only fund, we also guide you of where to go to get full cover. Maybe two additional things that I think have become quite important in creating peace of mind. You get funding, but you also care about the quality of care that people get. So I go to a hospital, I want to make sure that I get the treatment, I come out, I have no other infections that have since occurred since I've been in the hospital. So again, we work with hospitals and our partners to make sure that our members get the best quality of care in the system. The final component, which has really become highlighted, especially in the time of COVID, is the experience of people when they're in the healthcare system. You need to think about it as an ecosystem, not just I go to a doctor. But after you go to a doctor, what happens? You need medication, so you need to go to a pharmacy. At the pharmacy, we need to think about the experience. Can a person just go in, get their package, and leave without having to pay anything else? Or we should think even further. In the time of COVID, we had to think about the experience of not going into a doctor, because that puts you at risk. So we came out with virtual consult. So we think of it as an ecosystem where you create a peace of mind, you fund the member, you provide quality of care, and then you make sure wherever there's a touch point in that system, you provide a quality experience.
So what goes into selecting a plan? I mean, whenever someone has to look at getting a medical aid, you're confronted with 1,000 plans you could potentially pick from you guys, from many other providers as well. But how does one select a plan, and how do you guys guide people in selecting plans? And then a lot of the inserts are spoken to it as well, looking at the fine print and putting that out so that people actually understand what they're picking.
Musa, I mean, you make a brilliant point. Medical aids are complex, right? There's regulation, there's how you price, there's plan types, different plan types, there's benefits within those plan types. And I think at the nub of it, and what people don't realize, is that you have an advisor. Financial advisors play a critical role in this space. And they're not necessarily paid out of the member's pocket. They're paid as part of your premium contribution. We pay the financial advisor to be able to provide this quality advice. So many people don't even know that they have an advisor. I would encourage you to find out who your advisor is, because your advisor on a monthly basis is remunerated in order to advise you. And it is critical that when you choose a medical aid, so I'll give you an example. In our particular space, we've got 23 different plan types.
Okay.
That's a lot.
That's a lot.
Each plan type has different benefits. Within the benefit stack, there are also certain nuances, as an example, in terms of the level of cover, the level of funds that are available. So my recommendation, when you look at, it doesn't matter whether you're looking at Discovery or you're looking at someone else, obviously I encourage you to look at Discovery, but when you do choose, you speak to an advisor, number one. Number two, you choose a provider that gives you flexibility, because your needs change. Your medical needs today might be, you know, I'm young, I'm fit, I'm healthy. Tomorrow, your medical needs might be, I'm unfortunately dealing with cancer and I need something different. The second consideration is cost. Today, I'm employed and I'm doing well. Tomorrow, maybe for whatever reason, I lose employment, I go somewhere else, and I'm paid slightly differently. So the flexibility, you need to choose where there's flexibility, where you can either go up in terms of plan types based on your needs and go down, both medical and financial needs. But use your financial advisor.
So use your financial advisor, I think, is something that, you know, will take out of this. And an important thing that the financial advisor, I'm assuming in this case, would need to do is advise you on the type of plan that, you know, you need to pick. But in that plan, there are different things and different costs for different things, right? So if you're on a comprehensive plan, for instance, and you're someone that can afford to go see a GP, but how is the cost breakdown inside of each plan? So let's use a comprehensive plan for an example.
Yeah, so maybe let me take one step back. We've got 23 plans is a lot, but we cater for entry-level type of, I guess, entry-level an entry-level price, and then we cater all the way to an executive plan that could cost up to 7,500. Entry-level being at about 960 rands. Critical, when you sit with your financial advisor, there are two key considerations. What is happening with me from a healthcare perspective? Am I young? Am I healthy? Do I have chronic conditions, etc.? The second is very simply, how much can I afford?
Yes.
And based on where you are, your financial advisor will guide you. There are two components in terms of what goes into a medical aid plan, so to speak. There's the out-of-hospital stuff, the day-to-day stuff.
Yes.
I need my GP, optometrist, dentistry, all of those things that touch you and me on a daily basis. The second component is hospitalization.
Okay.
And medical aids probably play the biggest role in that space. That's my emergency cover when I'm in a car accident or I have a heart attack or a stroke. And that's also my maternity cover, my tonsillectomy cover if I need to take out tonsils.
Yeah.
So those are the two key components. So the medical aids that might include a hospital component and not a day-to-day. And I could say, you know what, I can fund for my day-to-day cover so I'm comfortable.
Yes.
But there are also plans that will fund for both day-to-day and will fund for your hospital cover. Also the level of funding. So at Discovery, we are really concerned about out-of-pocket expenses.
Okay.
There was a gentleman that I think you showed earlier who talked about the fact that he had diabetes and he had to have different procedures and that there were co-pays. Co-pays are killers, especially in this economy. So really the thinking and what needs to go behind it is, one, make sure you're on a plan where there's no co-pays. And you can get network plans that can give you full cover. We will just direct you in terms of where you go in order to get the right treatment and the right type of cover. So your financial advisor's job is to say, what do they need from a medical perspective and what costs or what price can they afford? Put those two things together, educate you on your plan, and then set you on your way. The medical advisor, the financial advisor also plays a role in coming back when you have problems. You showed the lady who was talking about her mom. She should be phoning not just a medical aid, my advisor. Advisor, our circumstances have changed. My mother no longer works. We need to downgrade our plan, but we still want full cover.
Yes.
These are the issues that my mom still faces from a medical perspective or a healthcare perspective. Therefore, where should I go with this? And then they should be advising you on what to do in order not to be exposed to unforeseen costs in the healthcare system.
So there's this idea, especially around the discussion of unforeseen costs, where a lot of people would discuss this prescribed minimum benefits, that there are these basic things that, you know, the medical aid has to pay for, in theory. So what and who determines what those things are? For instance, you've heard Ms. Golden in her interview there speaking around this idea where, you know, there are certain things that are paid for, other things that aren't paid for, and I've got this condition that has now developed and the medical aid has rejected that. How do we navigate that space, and who actually determines what is something that the medical aid can and can't pay for?
So the medical aid industry and the schemes are very regulated. So the two sort of key governing bodies, one being from Medical Schemes Act and another one called the Council of Medical Schemes. And what is critical about that is that they regulate this environment to ensure that members are treated fairly when they navigate the environment. Prescribed minimum benefits, and you know, these words are jargon, right? So when you're choosing medical aid, you don't have to think about what is a prescribed minimum benefit, what is not. You need to choose cover that is right for you. But really what they were trying to do, and this really comes from the regulator, is that there's a package of care that no matter what plan type you're on, no matter what benefits you choose, this package of care must be available in all plans for all members, which means it provides some key cover, such as emergency cover for an accident, for a heart attack, that you might be in your waiting period as an example, but that still will be available for you because it's a prescribed minimum benefit. But I go back again to the simple terms. Find cover that suits your needs. Do not worry about the jargon. Let your advisor worry about the jargon. Let the medical aid worry about the jargon. Find cover that will give you what you need for the life stage that you're in. Another lady that, or rather the gentleman who spoke about diabetes. Diabetes is a chronic, right? Almost all medical aids cover chronics. So if you just find the right plan for yourself and the right medical aid, we don't only cover the chronic. In addition to covering the chronic, we'll go as far as ensuring that we provide more support, such as programs where you'll get a coach, as an example, who will talk you through your diabetes or your chronic, the chronic cover that you need. So prescribed minimum benefits regulation, the regulator pretty clear and stipulates what is needed. They approve all the plans we submit.
Yeah.
They approve the benefits within the plans.
Okay.
So they really make sure that they look after the public and they keep us as the medical scheme and the medical administrators honest.
And lastly, I think an important one is this term that a lot of people that might be on medical aid or previously would have been on medical aid will hear is you've run out of funds. How does one run out of funds when you've been paying monthly contributions and continue to pay on a monthly basis for your medical aid?
Good question. Most medical aids that run out there, including Discovery's medical aid, have two components. The one component is what we call your MSA. That's basically the member savings account. So that is usually for your day-to-day cover, and you can run that amount the way you want to run that amount. So that can go up to 25% of your contribution. The rest is what we call risk cover, and risk cover we manage. That's when you want to go into hospital. And, you know, it's critical to understand the difference, because when you're in hospital, the amount can go as high as a couple of million. In 2020 alone, our top 10 claims cost us 72 million. That is the pooling of the funds and us working with providers, professionals, hospitals, etc. The top claim was 13.5 million for one individual, a 75-year-old member who needed to go into hospital for COVID-19. So that's the risk cover. That doesn't run out. That's us working with the data, working actuarially, understanding how to use this money to fund all of the members. On the other hand, you have what you call, like I said, your MSA. What happens with your MSA, you use it the way you want. You can say, I'm going to see a GP. Your GP might be, as an example, one that's on our network, and therefore we reimburse at a network rate. Or your GP might say, I'm not working with any medical aid. I will charge you maybe 3 times what most doctors charge, because I think, you know, that's what I want to do as a health professional, and you have to respect that. You can use that any way you want. You can go get spectacles, you know, and get the best frame, and you can say, I choose to use 15,000 of my medical aid. So really the power there is in the members' hands. So when you've run out of funds, at least in the Discovery universe, you're not running out of any risk funds. We will still be there for you in your time of greatest needs. What you might be running out of will just be your MSA, and that's based on how you use it. What we do, though, because that is critical, and that goes to quality of care, how the funding happens, and the experience, is that we support you. We say, these are the doctors that are on the network. This is exactly what you'll pay when you go to this doctor. If you go to this pharmacy, and if you choose a generic, as an example, as opposed to an ethical drug, we will fund it. Same quality, same outcome, but we will fund it, and it will be funded at, it will be at a lower amount. So we support how far your MSA can go. You can choose, though, whether to use that or not to use that. And that's when people say, I've run out of funds. The only thing maybe to note, and that's why it's so important what medical aid you choose, the only thing to note is on the risk cover, there are certain restrictions depending on what you're going into. So you might choose a plan that says, you know what, if you go, as an example, and do a hip replacement, there'll be a co-payment. That will be in the T's and C's. So if you are an elderly person who's been struggling with joints, etc., do not choose a plan that says the co-payment for that will be 30%. Because at the time that you have to go for that operation, it might not be for all procedures, but for that operation, 30% will apply.
Understood,
It will be a cheaper plan because there's a co-payment, maybe slightly cheaper, but the co-payment will apply. So choose the right plan for yourself.
It's about informing yourself more than anything else. And I think all those lengthy, long pages that speak to the terms and conditions need to be addressed, and we need to actually look at them and not just skip them. That was Nongolego Picha, the head of new markets at Discovery. After the break, we speak to Cheslin Jacobs, executive head of sales and services from Time Health, about what the difference is between medical aid schemes and health insurance. Stay with us. Welcome back to Vital Signs. I'm Dr. Musam Tombeni, and I'm sure you're wondering, what is the difference between a medical aid scheme and a health insurance or a hospital plan, and which one is the right one for you? Now, the choice between a medical aid scheme and a health insurance policy depends on your lifestyle, your needs, and most importantly, your budget. And the cost between the two differ because the products offered by the different services offer different benefits. Joining us to talk about health as well as health insurance, we're joined by Cheslin Jacobs, executive head of sales and services services from Time Health. Good day, sir. Thank you so much for joining us.
Good day, Musa. Thanks for having me.
Good. So before we continue our discussion, there is a tweet that came through during our first chat with Nonkululeko. It says, shortfall payment makes us doubt the services we receive in the medical sector. Paying medical aid, we expect them to take care of what we cannot afford in future, as we don't save money separately from medical bills. Let's hear your opinion on what Raymond has said.
Yeah, I mean, it's slightly different, a little bit out of my wheelhouse, Musa. You know, so our focus has purely been on medical insurance, and there's some substantial difference between medical insurance and medical aid. But I think I was listening to what Nonkululeko was saying, and I think the important thing is for us as individuals, when making these insurance decisions, is to understand what our actual needs are based on our lifestyle and where we're at in our lives. And I think that becomes really important. And I think that advice you provided around making sure you get the right information from your advisor becomes critically important. And I think just based on Raymond's tweet, it's purely been a mismatch between what his expectations was and what he's actually covered for. Again, so I'll go with what Nonkululeko said is seek the advice from your advisor and make sure that the plan you've taken matches what your lifestyle needs are.
The plan you've taken needs to match what you actually are experiencing in your life at that point in time. So let's get into it. Medical aid versus medical insurance versus hospital plans. What is the difference? What does each one mean?
Yeah, so like Nonkululeko said, medical aid is governed firstly, it's regulated, and therefore its main focus is in-hospital benefits, specifically around your prescribed minimum benefits. Whereas medical insurance, it's not subject to the same regulation, and its main focus is on primary out-of-hospital day-to-day care. Hospital plans, again, the big focus there is in-hospital cover. But I think if one looks again at one's lifestyle needs, with medical insurance, the primary focus there is covering you for your day-to-day medical requirements, and specifically out of hospital. I think the important point to make, Musa, is if one looks at medical aid, I think the numbers about 9 million South Africans are covered by medical aid and therefore have access to private healthcare. And if one looks at 9 million, is what, that's like 15% of the country's population at this point in time, which then predominantly means that the rest of the country is purely serviced by public healthcare system. We also know what strain that puts on that system. And I think with medical insurance and the price points that Time Health's plans specifically come in at, it's all about giving access to broader South Africa to access primary healthcare in the private sector.
So how does it work? What does Time Health's, I guess, package in this sense with respect to medical insurance work? Is it and you've spoken to the idea that it's an outpatient-based sort of service for those sorts of things, but how would a clean example, for instance, look like?
Yeah, so it's quite simple. You become a customer of Time Bank. It's a 5-minute process. You know, we think it's the easiest way to become a bank customer the world over, for that matter. It's a 5-minute process. And once you're a Time Bank customer, you simply sign up for Time Health and one of our plans inside our banking application. It will take you, the end-to-end process was probably 10 minutes. The nice thing about the Time Health plans, Musa, is there's 3 different plans depending on what your needs are as well as what your budget is. The entry-level plan comes in at 139 Rand per month, and call it the top of the range plan comes in at only 399 Rand per month. And what, for example, if I just give you a couple of examples of what's covered specifically in the top of the range plan at 399 Rand a month, you get access to your general practitioner, so doctor consultations. You get access to basic pathology, so blood tests, basic radiology, which is X-rays, acute medication, chronic medication on basic dentistry, basic optometry, access to specialists if need be, as well as accidental hospitalization and accidental casualty cover. So again, so if one looks at what you're paying for at 399 Rand per month, the fact that you've got access to a range of network partners in private healthcare, it's massive value, we believe. Again, kind of looking at what the country's been through, what the world's been through over the last 2 years, I think it's kind of heightened the need for appropriate healthcare for all. And I think this is one more product that allows, call it broader South Africa, to access private quality healthcare a lot easier and more affordable than ever before.
What limitations then exist with respect to insurance versus a medical aid? So, I mean, I think Nongulego spoke to this earlier on, the idea that a medical aid generally cover the most of the money is being spent on inpatients, and you're suggesting and highlighting the idea that insurance covers outpatients. But where does the limit exist between you and the service that you offer with respect to medical insurance, and how far it can go?
Yeah, like I said, the big difference is that in-hospital versus out-of-hospital. So again, insurance covers a wide range of out-of-hospital, your day-to-day benefits, which we know is massively important to ordinary South Africans, whereas medical aid it's a lot of obviously in-hospital benefits. So for example, medical insurance is not going to cover a hip replacement inside hospital for that matter, whereas medical insurance on our plans only will cover accidental hospitalization, but it's not going to cover any kind of elective procedures and things like that you might need inside hospitals. So I think that's the big differentiation, is that the in-hospital cover versus the out-of-hospital cover. But again, it's all based on your lifestyle needs. If one looks at the amount of time one needs healthcare that's out of hospital or day-to-day versus the amount of time you need healthcare in hospital. And again, where you are at your life and what that lifestyle needs are, I think that's the important thing always to consider, is to find a plan that matches what your lifestyle needs are. Now, again, like I said, there's only 9 million South Africans covered by medical aid, right? And the rest are not. And we think there's a massive gap, and therefore we've partnered with National Healthcare Group is to provide access to all South Africans to access private healthcare.
Mm-hmm. So can someone with medical aid then also take on medical insurance to cover the day-to-day things, or is this just duplicity at some point in time?
No, absolutely. We actually think that's a big kind of market where a product like Time Health will be really successful. So again, you could have call it a Rolls-Royce of in-hospital or hospital plans with your medical aid provider, so your in-hospital benefits are taken care of. But then you could also have a medical insurance product that supplements all your out-of-hospital expenditure. Nonkululeko spoke about MSA, so your member savings account, and those things predominantly take care of out-of-hospital and day-to-day benefits. It's essentially that account. And again, so medical insurance will do a very, very similar thing. We believe at a much better price point for customers and deliver a lot more value. And because with MSAs, you obviously have call it a capped amount that you've saved or that you can spend based on what you've contributed throughout the year. Whereas with medical insurance, you've actually got access to a wider range of benefits potentially for a longer amount of time, depending on what your needs are. So, for example, in the Time Health Elite plan, you've got unlimited visits to GPs as and when required within the network. And it's not capped at a specific rand value in that instance. So again, those two things can definitely coexist, Musa. So if you're on, like I said, a Rolls-Royce hospital plan or in-hospital benefit, we still believe medical insurance for day-to-day cover is massively important as well.
The big issue of co-payments, is this something that is popular in medical insurance, where there would be an element of co-payment as well? So although I have medical insurance and I know that I've got outpatient facilities that I can go to, will there be an element of co-payment that I need to top up to be able to see any of those either network or non-network doctors or specialists?
Yeah, so again, on our medical insurance products, it's all network related. So to get the insurance cover, you have to visit a network practitioner. So be it a GP, pharmacy, a laboratory, a specialist optometrist, or dentist. It has to be within the network to get the insurance cover. If it's outside of the network, like anything else, the patient will then be liable for those fees. So provided you are in the network, the medical insurance product will cover the costs.
All right. Thank you so much, Mr. Cheslin Jacob, Executive Head of Sales and Services from Time Health. After the break, we speak to Dr. Aquina Tulare, the technical specialist from the National Health Insurance, about the Department of Health's ambition to have private healthcare available for all the members of the country, and of course looking at what that will do to medical schemes once the National Health Insurance is implemented. Stay with us. Welcome back to Vital Signs. Now, much debate has taken place around the proposed National Health Insurance Bill. A central issue is the future role of private healthcare and medical schemes once the NHI is implemented. Now, the NHI bill states that when the NHI is fully implemented, medical schemes will not be able to provide cover for services that are paid for by the NHI. Joining us to speak about the future of NHI and how this will impact medical aids as well as other things, we're joined by Dr. Aquina Tulare, who's the technical specialist on the National Health Insurance from the National Department of Health. Good day, ma'am. Thank you so much for joining us.
Good afternoon, and good afternoon to your viewers.
Lovely. So let's get into our discussion. A lot of people have heard, this phrase, NHI is coming, it's around the corner. What does NHI actually mean, and what's government's ambition with getting NHI? What is the point?
Well, a national health insurance called NHI, it's a strategy that we are adopting as a country to move us towards what we call universal health coverage as an ultimate goal. A universal health coverage is aimed at ensuring that we cover everyone, no one is left behind, and we are covering for financial hardships and making sure that the services that we want to provide are comprehensive and people are not left with hardships because their services are not covered. We have heard from the previous speakers that people are told that, when they go into a hospital, they run out of benefits and they're expected to pay huge amounts of money, what we call catastrophic healthcare expenditure, beyond and over and above what they've been paying for in medical schemes. And then what also happens with the example that we got of the lady that has got lupus, that she has been paying for her medical aid throughout her working life, and when she retired, she had to downgrade. And then, as usual, when you get older, you get diseases. Even young people do get certain diseases that are quite complex, and you'll find that when you need to access services for those complex conditions, you are told that either you are not covered or you are covered but you must pay co-payments. So NHI is going to be implemented to ensure that all of us, irrespective of your socioeconomic status, irrespective of your employment status, you have access to a comprehensive set of benefits, good quality health care without being exposed to financial hardships. And it is going to be covering all. That is why we talk about universal health coverage. It's everyone, rich, poor, young, old, sick or healthy. All of us will be benefiting from national health insurance.
So what does that actually look like, Dr. Tulare? Is it, one of those things where I can walk into any facility whenever I want and be seen by anyone, private or public, and there is no cost to me? Is this a free service? And also, importantly, who is funding these the expansion of access to health?
So NHI will be contracting providers in both the public and private sectors. So what will be required of the providers is that they must comply with certain standards that have been articulated either through the Office of Health Standards Compliance for the quality aspect, but also in terms of performance, meaning that the providers will be expected to provide services, keep records, make sure that they are able to report to the appropriate authority on information that will help us plan for the population health. So all practitioners, all providers will be invited to contract with NHI, but they have to comply with these requirements. And it's basics where we expect that those that are going to be providing services under NHI comply with the quality requirements and they comply with performance. Who is going to be funding NHI? What we have said, and you look at the bill also, it talks about sources of funding, that NHI is going to be funded through general tax revenue, and it is going to be supplemented by payroll tax, meaning that those that are eligible to pay payroll will be contributing a small amount, a small proportion into the fund. And then there are also other sources of funding where, for example, the current tax rebates are going to be redirected into funding. This is very important because rebates currently benefit people who are able to either pay out of pocket or pay into a medical scheme, and they enjoy those tax rebates. But everybody else does not enjoy those rebates. So it tends to be slanted in terms of who benefits. And therefore, NHI is going to mobilize all these resources into one pool so that all of us have got one pot. We cross-subsidize each other. The rich will cross-subsidize those that have no means. The sick will be cross-subsidized by those that are healthy, meaning that if ever I develop my lupus later on in life, I'll be cross-subsidized by those that are healthier. And the young, because they are normally healthy, will cross-subsidize the older people. So those are the principles, and we call these principles commonly the principle of social solidarity, where we look after each other. And this is quite important also because we view health as a public good, not a commercial product, a commodity that is driven by market forces, but it's where we are all looking after each other. We have got a mantra here in South Africa of saying Ubuntu, and we look after each other, and that is the basis of NHI.
So what does NHI then mean for medical aids who, in theory, provide the service that an NHI, for instance, will then in future provide?
Well, NHI is going to provide more than what medical schemes are currently providing, but what is going to happen to medical schemes, because all of us, even those that are on medical aid, are going to be expected in law to make a payment into the fund. It's a tax of some sort that we'll all be paying. And therefore, it won't be necessary for people to be paying twice because that would be quite heavy for people to be paying twice. We need to pool these funds together. So medical schemes will therefore be providing services that are not covered under NHI. Noting that I have indicated that the services to be covered by NHI are going to be quite comprehensive. So schemes will be expected to cover services like what we call medically not necessary services. For example, if I want to do my nose job, or if I want to do an enhancement of my breasts, that would be what we regard as medically unnecessary. But all the necessary interventions are going to be covered, and there is a committee that is going to be looking at this, advising the fund and the minister. It's called the Benefits Advisory Committee. It will be consisting of experts in various disciplines of medicine and health and nursing and all the other allied disciplines, so that the services that are covered are comprehensive. The advantage of pooling is that if you have a big pool, then you know that there is going to be a balance where you will have a huge amount of people that are relatively healthy and an amount of people that are not well. But the principle of cross-subsidization will be taking a place at that level so that the risks are spread, even though we have people who are sicker and people who are healthier. So it's one pool that is looking after all of us. We know this thing even with our Stokvels. We use that, we pool our funds so that we can be able to buy more. And the fund will be using its buying power to make sure that it drives down costs, because one of the problems that we are currently experiencing and which is contributing to benefits being exhausted is the high cost of delivering healthcare in our country.
So at what stage is the NHI plan at this point in time with respect to implementation?
Currently, we are going through various phases. The one major phase that is visible, or there are two major phases that are visible. The first one is that we have been doing preparatory work since 2011, 2012, to prepare for a situation where we will be ready to implement NHI in terms of health system strengthening initiatives, looking at our infrastructure, our clinics, especially in the public sector, setting up other regulatory structures that are going to assist in ensuring that NHI, when the time arrives, we can implement. And then the second big phase that we are looking at is in terms of the legislative process, because for NHI to be implemented, you need the law. The law is currently, the law drafting process is currently in Parliament. Parliament had received written comments from stakeholders, and there were hearings also throughout the country where Parliament visited different parts of the country to hear what people wanted out of NHI. And now we are at that phase where now Parliament is considering all these inputs and comments, and they are going to debate, and then it will go to the various chambers of Parliament for further debating before the law becomes, before the bill becomes law and act. And then in the meantime, also there's other preparatory work where we are looking at the capacity of a future National Health Insurance Fund to manage the funds, and we are setting up that infrastructure in preparation whilst you are waiting for the law to be enacted.
Thank you so much, Dr. Tulare, for really giving us an in-depth look at what the NHI looks like and what the plans are with respect to that. Thank you for joining us today. And of course, thank you to all the guests that participated in our discussion today. And I think a big take home from this is that if you are thinking of getting a medical aid, planning on getting a medical aid, or currently on a medical aid, that you go back and read the terms and conditions and pick a plan that makes sense for you, so that you're not finding yourself in the dark and left on a lurch waiting for someone to pay, or being left with co-payments to pay. Thank you so much for joining us. We'll see you again soon.